about the obstructive lung diseases. I'm going to start with COPD. This stands for chronic obstructive. So if you remember what it stands for, it's the pathophysiology is really built into the name. So COPD. Anybody know what it causes? What causes COPD? Emphysema. So COPD is actually an overlapping of two different respiratory pathologies. Emphysema, and then the other one is chronic bronchitis. So those are two features of the underlying pathophysiology. The number one cause is smoking. 90%, more than 90% of COPD occurs in smokers. So that's really the main cause. There are a few people who probably have increased genetic susceptibility and maybe get it from increased air pollution, other types of environmental exposures, but really we primarily see COPD in the smoker population. And clinically, most people have a combination of symptoms related to emphysema and chronic bronchitis. But to try to tease it apart and really illustrate what's going on, the underlying pathology, you can characterize these people as pink puffers. Pink puffers are people who have primarily emphysema, and blue bloaters. So these are people who have primarily chronic bronchitis. But again, in reality, when you see a patient, it's rare that you're going to see somebody who's extremely one or extremely the other. You'll often see an overlapping of clinical signs and symptoms or a transition between these two extremes. So here's a demonstration of the extremes. So we'll start with the blue bloaters. These are people who have pure chronic bronchitis. So bronchitis, this is inflammation of the large and small airways. And this inflammation is largely triggered by toxins in cigarette smoke. It causes inflammation of the bronchi. It causes mucus hypersecretion. You actually get both metaplasia and hyperplasia. Metaplasia of the ciliated columnar cells into squamous cells. Squamous cells are more hardy. They're against those toxins that are coming in. So that's similar to what we saw in the acid, except for it's inversed. So the ciliated columnar cells turn into squamous cells so that they're better able to withstand the heat and the toxins in cigarette smoke. And then at the same time, you get mucus cell hypersecretion, so those mucus secreting cells undergo hyperplasia. And both of those things, inflammation and mucus hypersecretion, contribute to constricting those airways. In emphysema, for reasons that aren't really well known, other people who are exposed to cigarette smoke may develop more emphysema physiology. And this is destruction of the alveoli. So the bronchi seem to be relatively unaffected, and instead, the toxicity occurs at the level of the alveoli. And so you get destruction of the acini down at the end. It occurs after that terminal bronchiole right here. So these are the end bronchioles. And most of the destruction happens after that place. And so as you decrease that alveolar sac, you damage capillaries, and you also damage the pneumocytes that are living in there. And you end up with increased air spaces because these alveoli grow into each other. You're destroying the walls between the alveoli. So you destroy the walls, and those were the pneumocytes and capillaries. And the pathology, or the underlying pathophysiology of this is actually, I think, really interesting. Part of it we don't quite understand, but in chronic bronchitis, they have trouble getting air out. And so what happens is the body responds to that by decreasing the respiratory rate. If it's harder to breathe, they decrease their respiratory rate. And they counter that by increasing cardiac output. So often they'll have left ventricular hypertrophy. So their left ventricle is trying to pump the blood out higher. That increases stroke volume. And they're also going to increase their heart rate. Because remember that cardiac output was stroke volume times heart rate. So the body compensates for this decreased respiratory rate and decreased ability to breathe by increasing cardiac output to still try to get blood flowing, oxygen to the rest of the body. But when you decrease respiratory rate, they end up with hypercapnia, which was, remember, an increase in CO2. They also have hypoxemia, which is a decrease in O2. And so you see the blue cyanotic appearance is related to that hypoxemia. So this is a hypoventilation. Their respiratory rate is not high enough to maintain gas exchange. And as a result, they have a lot of hypoxemia and hypercapnia. So hypoventilation. In emphysema, you have destruction of the alveoli, but the remaining alveoli are okay. So as long as they can get enough air in and out of the lungs, what alveoli remain are still able to undergo gas exchange. So they compensate by increasing their respiratory rate. So it seems like they're hyperventilating, but they're just ventilating enough to maintain gas exchange. So they have a relative normal blood gas. Why, in this picture, why do you think this man looks so thin? Any ideas? So his alveoli are being destroyed. The elastin in the walls of the alveoli, that's what provides most of the recoil to help you when you're exhaling. And so in order to make up for that loss of elastic recoil, in emphysema, they have to use their respiratory muscles much more than you. So this guy with emphysema, he's sitting here. You're just sitting normal and it feels comfortable for you. He's got to work really hard just to maintain his normal oxygenation. So he goes like this. That's a pink puffer. He's leaning forward. That actually helps with the muscles of respiration. It puts them in a better position biomechanically. And he has to really use his muscles. So you can see his accessory muscles, his muscles around the collarbone, his muscles around the diaphragm, the chest wall muscles are being really worked hard. And so he's actually burning a lot of calories. And he can't keep up with it. Any questions? Does that kind of make sense what's going on with these two extremes? Yes. By the time, emphysema is not reversible. Because you really destroyed those walls, they don't grow back. You can stop it from getting worse. So if a person has emphysema and they are still smoking, if you can get them to stop smoking, you can stop the progression of the disease. And at this stage, this person probably still has some alveoli left that are normal. And so it'll always be hard for him to breathe. He won't be able to reform the old alveoli. In bronchitis, it depends. So there's some aspects, like the mucus hypersecretion can actually be partially reversible if you stop the insult, you stop smoking. The fibrosis, once you've gotten chronic inflammation that's lasted a long time, that fibrosis in the airway wall, similar to what you can see in the hardening of small arteries, that's not reversible. So some aspects of chronic bronchitis could be reversed, but emphysema can't be reversed. Question back there? So the bloating is because of air trapping. So the other thing is that this tends, for reasons we're not quite sure, this tends to happen in people who have metabolic syndrome, tend to be more overweight, they have high blood pressure. So it's probably something about their underlying genetics or metabolism that also contributes to them developing more bronchitis than emphysema. But the bloating in the chest, and they are blue bloaters, is because of air trapping. So that air comes in and it doesn't get back out. Remember when we talked about the increase in residual volume? So now he's not able to exhale as much air as he used to be able to exhale. And so all of that extra air is really trapped in his lungs. It's not undergoing gas exchange, so it's not able to get fresh oxygenated air in. It's just that carbon dioxide loaded air is just hovering in the lungs. It's never getting exchanged. So that's where the bloating comes from. Any other questions? So here's the morphology of emphysema. This is what I was mentioning. The alveolar walls just become destroyed. And what this probably is that the pneumocytes in people who tend to get more emphysema, those pneumocytes are very sensitive to the toxins in cigarette smoke, and they die. You also, in response to cigarette smoke, just like with bronchitis, in the alveoli you start to get inflammation, but that inflammation is destroying the cells in the acini rather than causing the fibrosis. So the walls become destroyed, the air spaces become enlarged, and you can actually see that on gross morphology. So if you look at the lung on autopsy of a person who has emphysema, it really has this honeycombed appearance. And these are big holes. And these holes mean that there's fewer capillaries and fewer opportunities for gas exchange to occur. So they're just holding that dead air space. So the pathogenesis of this, again, tobacco smoke is the biggest factor. It releases a lot of toxins. It also generates reactive oxygen species. And one of the interesting things is that these toxins and reactive oxygen species tend to inhibit some of the normal proteases that are occurring in the wall. So in the lung, the pneumocytes secrete proteases, and one we know a lot about because there's a genetic disorder is alpha-1 antitrypsin. So the normal job of this is to inhibit elastase and other proteases. When you have inflammation in response to some of these toxins, elastase is secreted as a byproduct of the neutrophils. It's one of the chemicals it secretes to try to harm bacteria and other pathogens. In this case, it's causing tissue damage. So it actually breaks down the tissue. In order to try to curb that response, your cells, because we're exposed to quite a few pathogens in our lungs, this is a barrier tissue. So the lungs secrete an alpha-1 antitrypsin and other anti-proteases to limit the damage that can be caused by that. So if these proteases are inhibited by cigarette smoke, now you've lost that protective function, and the elastases kind of have free rein. They go out of control, and they really break down the tissue. So you get a lot more tissue damage in response to inflammation than you would in another type of disorder where you weren't inhibiting these proteases. And this has all been worked out. So I did tell you about another type of lung pathology, the restrictive lung diseases and the interstitial fibrosis. But emphysema is actually an obstructive disease. So why don't you get that interstitial fibrosis with the chronic inflammation in somebody who has emphysema? Take a minute, talk to each other, see what you think. All right, so let's look at chronic bronchitis now. And compare this, think about what you saw with emphysema. So remember, with emphysema, we just see a lot of destruction. With chronic bronchitis, now we're looking in the bronchial walls. So these are your small and large airways. And you see these key features. So what is this arrow pointing to? So what we're looking at up here is you're seeing goblet cells, or the mucus secreting cells. You also have a loss of ciliated columnar cells. And I realized I should have put, next year I will put a normal image up here so that you can, to remind you what the normal bronchi look like. But in here you have a combination of hyperplasia and metaplasia along the epithelium. And then here, the goblet cells secrete like a thin layer of mucus, but you know that really thick stuff you cough up with bronchitis? That is secreted by these gland cells. So you get glandular hyperplasia. And that happens actually within the wall of the bronchi themselves. And then down here, what do you think that arrow's pointing out? Inflammation? So, yep. So you also get inflammatory cells. And you'll, depending on where that person, that individual is in the development of chronic bronchitis, you'll see a lot of inflammation early on, and a lot of the cytokines that are secreted by those inflammatory cells induce the gland cell hyperplasia. The chronic exposure to toxins is what induces the metaplasia in the epithelium. So you'll see a variety of different histologies within somebody who has chronic bronchitis. But what you'll get from this is you'll go from a normal bronchi to this thickened wall and mucus, extra mucus within the tubes. So both of those factors increase mucus, increase bronchus wall thickness, are going to lead to airway restriction. And that increase in wall thickness, again, is a combination of hyperplasia of those gland cells, but you'll also get fibrosis or scarring with chronic inflammation in the wall itself. So the walls can also become stiffer, less pliable over time. Okay. So this is something that's a new question out there. Electronic cigarettes. So the cigarette industry in the United States and many Western countries that have seen a dramatic reduction in smokers have tried to recapture some of that market share with electronic cigarettes. So do you think they're safe? You can't just say no. Why not? First of all, who knows what an electronic cigarette is or what it does? Can somebody explain it? I've never used one, so I don't actually know very well what they do. I have a general concept. And even if you do know, I won't think you're a smoker, don't worry. Yeah, so it's a vaporizer. And so you put in, it comes as a liquid. And I think that liquid has tobacco in it because it's basically a tobacco delivery device that's supposed to be, instead of a smoke, delivering the tobacco with smoke, you deliver it through vapor. So you still get tobacco. Yes?
I'm pretty sure it's the isolation about nicotine, because the nicotine is causing an addiction, so this is supposed to be safer than bringing all that tobacco toxins. It just gives you nicotine.
So you think, so they actually isolate the nicotine from the tobacco? They don't just, okay, so it's not like tobacco juice that they're putting in there. Yes?
So like, would that mean that it's also like not carcinogenic if you use vapor instead of smoke?
Well, that is the e-cigarette industry's health claim, is that if a lot of the toxins that happen with smoking come from the combustion of tobacco. And so tobacco, it has nicotine in it, but it also has a ton of other things. And it's a leaf, it's a plant. Anytime you burn something, you burn wood, you burn plant matter, you're combusting all of those organic molecules, and some of those produce carcinogens. Yeah?
We're discussing electronic cigarettes, or we're also discussing vaping devices?
Is there a difference? Okay. I don't know. I know that there's like that vapor store out by New Yogurt. I didn't know there was a difference between vaping. This is good. I'm learning too. Between vaping and e-cigarettes. So,
There's a lot more like corn, glycerin, nicotine, vaping. I'm assuming tobacco products, but
okay.
different substances in which are vaporized in order to inhale, but heat more specific.
Good. So Ian was saying the vapors in vaping are different. It's like corn and glycerol mixed with nicotine. And I'm not exactly sure what they put into e-cigarettes. Yes?
The main difference between a vape and like an e-cigarette is like an e-cigarette is like a cartridge kind of.
Okay.
And so the stuff is like already in there, and I think you like buy them separately. So you just have like an e-cig that like lights it, and then you like get the cartridge and you like screw it on or something. Because I've seen.
Okay.
And then vape is like you have liquid and you like put it inside of the little cartridge that is like already.
So with the e-cigarettes, you get them and they already have the cartridge, or you put the cartridge directly in there versus buying the liquid separate and putting it in. And the cartridge in e-cigarettes, I'm not sure if it's just the same kind of liquid.
And I think you can like depending on what you get, like what type of liquid or cartridge, it's like nicotine or.
Oh, so you can actually get nicotine-free ones, then what's the point? I think it's probably to help people wean off from smoking. Because a lot of smoking addiction, it's partially a nicotine addiction, but it's also this you become very addicted to the behavior of pulling out a cigarette, holding it, all of those things. So maybe based on what you were describing, e-cigarettes are better for somebody who's trying to transition from a cigarette, because you can still have some of those behaviors without the nicotine and try to get yourself off from that addiction versus vaping. And I think with vaping, you can buy different flavors and stuff. Yes? With vaping, you can adjust the amount of nicotine. Interesting. Oh wow! So with vaping, you can go from 0 to very high levels of nicotine. So if you're really, really addicted, perhaps being able to just get a nicotine bolus that way. Maybe it's like the gum, right? You get some nicotine in a different format as an alternative way of getting off from cigarette smoking. Yes?
I've heard that vaping has been, or there's possible correlation with vaping and causing popcorn lung. Have you heard about that?
No, I haven't. I would imagine it might be related. So popcorn lung sounds to me somewhat like emphysema. I don't even know. I've never heard the term popcorn lung.
Oh, really? I don't know. I've heard that. I'm trying to think. What did I say?
So what do you think might still be dangerous? Let's assume that e-cigarettes and vaping are both, you're vaporizing corn oil glycerol with nicotine instead of the tobacco leaf. Would that still be dangerous? So what is it about smoking that's actually dangerous? There's a lot of things that are dangerous. It goes straight to the lungs. All of those toxins go straight to the lungs. With this, it's still going to go straight into your lungs. I think you're still going to have high heat exposure. So heat is one of the factors that can cause damage and cause that columnar to squamous metaplasia that goes on. So you might still get a little bit of that. I don't know what vaporizing corn oil does, and if there are any carcinogens related to that. I know that it is being researched right now because the e-cigarette industry is really trying to get approval to remove certain safety labels. But let's get to nicotine itself. Is nicotine dangerous?
Yeah.
What is dangerous about it? Anybody know? Yeah?
I think it affects the neurotransmitter dopamine, and elicits a certain, it basically elicits a pleasure effect, and then if you are putting too much of your dopamine into your brain, your receptors are going to deteriorate and stop.
So, it affects the brain, it affects neurotransmitter levels in the brain. It does affect dopamine, which is your reward system in the brain, but it does it indirectly. It actually binds to nicotinic acetylcholine receptors. So nicotine binds to these acetylcholine receptors in the brain. And acetylcholine in the brain is kind of actually produces a wakefulness and attention. So a lot of people like cigarettes because it helps them feel like they're able to attend to things and actually calm down. So you get bathed in acetylcholine, you become more focused, less jittery. And it, through that acetylcholine pathway, also activates the reward mechanism through dopamine. And there can be, over long-term exposure, some receptor desensitization to it, where you need more and more nicotine in order to get that effect from it. But nicotine itself is highly addictive. But if you get off from it, I don't think there are long-term consequences to the brain. I had a friend in grad school who was studying this mechanism, and he swore that when he hit 60, he was going to throw on a nicotine patch, because nicotine actually does have some neuroprotective effects over time. And I'm not trying to convince you guys to go smoke, because smoking is bad. Smoking causes cancer. Smoking causes endothelial damage and atherosclerosis. It causes heart disease. It's just bad. But the nicotine itself is not. So I'm actually undecided on this question. Yes?
I recently read a study, I can't remember the name of it, but they're looking at giving nicotine for people with really high anxiety levels because it actually has less side effects than a lot of the anti-anxiety medicines.
Absolutely. Oh, that's really interesting. So yeah, nicotine, and a lot of people self-medicate. So prior to this boom of psychopharmacology, a lot of people would self-medicate with cigarette smoking because nicotine does have that reducing anxiety benefit. And so if you can deliver nicotine purely, I can see that it would have an anxiety-reducing benefit without all the side effects of Strattera or sertraline or some of these other pharmaceutical agents that try to, that are prescribed for anxiety. Yes?
You said that it contains neuroprotective capabilities?
Nicotine, yeah, has some neuroprotective mechanisms over time.
I thought that it overloaded receptor receptors, kind of like the way that cocaine and other drugs do. So
Yeah, no, it's actually, nicotine is not like cocaine. So cocaine actually upregulates dopamine, that's how it has its reward. But it actually it acts directly on dopamine and it acts directly on norepinephrine. So cocaine is like a really strong version of coffee, because coffee does that as well. So it's because it's acting on those two neurotransmitters directly. Cocaine has a huge effect. It's also very addictive, but it can suppress breathing. It can have a lot of bad side effects. Nicotine upregulates dopamine indirectly through its effect on acetylcholine. And so because they're going through this secondary mechanism, it's only really activating the nucleus accumbens, which is the reward circuit in the brain. So you don't get the same side effects with nicotine as you do with cocaine and other stimulants. But that's really interesting. So going back to this, currently, American Lung Association and the CDC do not recommend using e-cigarettes. So American Lung Association is concerned about the health consequences and so far claims that it can help people quit smoking in a healthy way. There has just not been enough data to support that. Here's what the CDC says. There's some substances which include trace metals of volatile organic compounds. So you're vaporizing, you're volatilizing these chemicals, which are lower than normal cigarettes, but still may have some unwanted health effects. Yes?
Okay, this is going to be a crazy thing to say, but is nicotine similar to heroin, where heroin you can't get off of it because you need more and more and more?
So nicotine does have a similar receptor downregulation effect. It's the problem with heroin and the opioid
I know
system
that's totally different.
is that opioid, when you overdose on nicotine, you just get kind of really attentive, hyper, maybe even a little bit paranoid, but it doesn't carry with it the risk of death. If you overdose on opioids, it suppresses your breathing and you just stop breathing
But
and
it
you die.
doesn't have that same, like, if I don't have it, I'm going to start to, like,
It does have if I don't have it, I'm going to want more of it. So that addiction is the same. The receptor downregulation is the same, but the physiology of what that means for if you escalate how much nicotine you have, you can take more and more nicotine, and you're not going to get to an overdose of close to death, the same way you would with opioids. And it's probably a little bit less where you don't escalate as fast as opioids. And I think it would relate to, you get some of that reward activation through nicotine, not nearly as much as you do with the opioids. Yes? I'm not sure. Some kind of chemical. What are nitrosamines? Yeah. So I liked organic chemistry, but that was a long time ago. So maybe somebody here in organic chemistry remembers what nitrosamines are. They're amines that have a nitrogen group on them. So. All right. Two forms of asthma, atopic and non-atopic. There's actually probably 10 different types of asthma. Broadly, we can bin them into atopic versus non-atopic based on the pathophysiology. So atopic is part of that atopic triad that goes along with allergies, seasonal allergies, or allergies to food, other things like that, and atopic dermatitis. So what type of hypersensitivity is this? Type 1. So this is a IgE-mediated hypersensitivity. So you're exposed to an allergen, and remember, an allergen is something that causes it causes a type 1 hypersensitivity where in the rest of the population it would not cause any kind of reaction. So some kind of allergen, and people with asthma spend a lot of time trying to figure out what their triggers are. So it could be pollen, it could be other types of dust mites, things like that. Your first exposure primes your B cells to start making IgE. Those IgE attach to mast cells and just sit there. You have a lot of mast cells in your airway. Next time you're exposed to that allergen, those mast cells bind the allergen through the IgEs. That aggregation activates the mast cells and they immediately degranulate histamine. So you get vasospasm, you get bronchospasm. So those airways, in response to histamine, immediately start to tighten up. The smooth muscle spasms, the capillaries that feed it become leaky and you get edema. So the airways quickly close up. Non-atopic dermatitis is any trigger that's not an allergy. So this is a non-allergic mechanism. So the triggers are not allergens. These can be things like a virus. So go down here. Some types of viruses have been linked to the onset of asthma. It can be toxins, air pollution, drugs. Some people have asthma in response to taking aspirin, and any kind of environmental. And what happens is these things also trigger inflammation. But not through IgEs and mast cells. So they trigger inflammation through activation of macrophages, recruitment of neutrophils, your classic type of inflammatory response. And this is an acute inflammatory pattern. Just going to breeze past this one. You can look through this diagram in a little bit more detail to remind yourself the pathogenesis of that type 1 hypersensitivity. But the big question is, why do some people have asthma and other people don't have asthma? Whether it's an allergy or a non-atopic asthma. It seems that there's a lot of risk factors. There are some genes, so people could have some genetic susceptibility, But there's also a lot of environmental exposures, including in utero, so exposures when you're still in the womb. Early exposure to microbes seems to have a big role in the development of asthma. And then again, this exposure to pollutants has a big role, but all of it seems to activate these T helper cells and induce both acute and chronic inflammation. And asthma is a progression over time. So usually you end up with, you'll get these acute asthma attacks. That's an acute inflammatory response. And then it actually goes right back to normal. So if you have somebody who's coming in and you're trying to figure out if they have asthma or if they have something else, the biggest distinguishing factor is that asthma is reversible. Unless it's very late in the disease stage, asthma is reversible. So you can give somebody epinephrine or corticosteroids, and that relaxes the smooth muscles and opens the airway, because it's mostly a bronchospasm that's causing the airway restriction, opens the airway, and suddenly their FEV1 normalizes. Whereas somebody who has chronic bronchitis, you can give them corticosteroids, but they still have that hyperplasia and hypermucus secretion, and it's not reversible. So let's look at the morphology here. Here's a normal bronchus, and so here are the ciliated columnar cells. And over here, you can see this metaplasia, where you have a lot of goblet cells. Taking over where those normal columnar cells are. So that causes a lot of extra mucus, but you don't see as much that, remember we saw those glandular hyperplasia in the bronchial wall with bronchitis? You don't see that with asthma. Instead, you do see a lot of inflammatory cells. So just beneath the wall, here are a lot of inflammatory cells. Okay, I'm going to skip this question. I'll let you guys use that as a practice question when you're studying. All right, any questions? I know I kind of flew through asthma. Yes?
For the asthmatic bronchitis,
Restrictive lung diseases. The main class of these, there's the chest wall and then the chronic fibrosing diseases. So we talked about emphysema, where you have a destruction of the alveolar wall. This is, in many ways, you're still destroying the alveoli, but instead of opening the air spaces, you actually fill those air spaces with scar tissue. So the etiology is interstitial fibrosis related to chronic inflammation. And again, it's really important to point out, in emphysema, you are getting chronic inflammation in response to that tobacco, but because of all the toxins in the smoke are killing your fibrosing cells, you don't get interstitial fibrosis. Silica, asbestos, coal dust, these are things that will cause chronic inflammation in the lungs, and they actually lead to fibrosis because that chronic inflammation or that stimulus isn't killing the fibroblasts. So they're activated, macrophages come into the area, and you get that extracellular matrix repair mechanism with ongoing chronic inflammation. And the symptoms, or what you'll see clinically with people who have chronic fibrosing diseases or any kind of restrictive lung disease, is, again, you'll have a decrease in the vital capacity. So they just can't expand their lungs. Now, some people with fibrosis, because that scar tissue is replacing the airspace, they may actually have a decrease in their total lung capacity as well. This extracellular matrix is taking over the air spaces rather than increasing them. So here's a person who has idiopathic pulmonary fibrosis. Unfortunately, this condition, we don't know why it happens. I actually had a patient like this when I was in med school. A woman, 35, just had trouble breathing, and it got worse and worse and worse. She was tested for asthma. She didn't have asthma. On lung x-ray, you just see this increase. It's just not quite as translucent as it should be, just a little bit of increased opacity. And then here on CT, you see that those walls between the alveoli become scarred over, and it gives you this kind of honeycombing pattern right here. Yes?
Why would it affect one lung more than the other?
We don't know. That's a great question. Why would it affect one lung more than the other? What we do know is that we don't have any kind of treatment for it. It's going to eventually affect the other lung. So it starts in one place. The progression can be highly variable. So somebody may start and present with idiopathic pulmonary fibrosis at age 35, and they may not reach respiratory failure until they're 65. Another person may have respiratory failure after 5 years. So it can be rapid or a more prolonged course. Yeah?
So aside from like hypertensing and having a hard time breathing, how would you know if you don't have a baseline before that symptom happened? How would you know if vital capacity or any of that capacity?
You don't. So Ashley has a good question. How do you know if things are changing? And you don't. If a person comes in complaining and they haven't seen a pulmonologist because they've been fine, has been told that day, that first visit becomes your baseline, and you track them based against that first visit. You can compare it to normal, so you can get an average based on their height and gender of what it should be. So if it's severely reduced, if their total lung capacity or their vital capacity is severely reduced from what you expect, that could be a really good sign. But you're right, you don't know what they were 10 years ago. So you just have to kind of watch the progression of it over time. Yeah?
Would a lung transplant fix that, or does it just get reinfected with the same thing?
No, that's a good question. A lung transplant would fix it. Again, we don't know what initiates this whole process. It's actually really interesting. There are similar diseases that are autoimmune, and I imagine in those cases, a lung transplant it'll buy you time because it takes a long time to develop, but it would eventually come back. But for idiopathic pulmonary fibrosis, I don't know if they actually do lung transplants very often, because unfortunately you can kind of see it's scarring down, and it scars against the pleura, and it actually pulls in over time. So it's changing the mechanics, and it's changing a lot in there. I'm not sure if they can I don't know. Maybe you can look it up and tell me. I know that it's really scary and really hard. And after a certain period of time, people have to go on oxygen, and they have to carry around oxygen with them because they're just not able to expand their lungs and get gas exchange. And eventually they'll have to go on a ventilator to try to, they can't ventilate themselves because their lungs are so stiff that they need that forced ventilation. And eventually they do die of respiratory failure. So here's what it looks like on histology. You get, again, here's the alveola, and here's all that interstitial space. So that scarring is taking over those nice thin walls where gas exchange normally happens. Now, air from here has to diffuse across a lot of scar tissue to get into the capillaries. And so that diffusion coefficient that something that they can actually measure goes up. It becomes much harder for gas exchange to occur. Plus, your lung volumes are decreasing, and your work of breathing is increasing because of that stiffness. So there's a lot of factors that go into it, but basically these people have very hard time with gas exchange. So they become hypoxic and hypercapnic, and they experience dyspnea, and it's this very uncomfortable feeling of just not being able to breathe, not being able to get enough air in. This is just a different stain. I think it's called a shift stain that stains scar tissue blue, so it gives you a really good picture of all the scar tissue that's going on in there. And then the other big type of chronic fibrosing disease is interstitial or hypersensitivity pneumonitis. And similar to asthma, things like exposure to dust, exposure to silica, for some reason in some people you will get that hypersensitivity reaction more in the alveoli than in the airways. And so the hypersensitivity pneumonitis is actually, it can be a type 1 or it can be a type 4 hypersensitivity. And it's different from asthma because it's affecting the alveoli. All right, how's our time?
5 minutes.
5 more minutes? Okay. So what you're seeing here is an influx of inflammatory cells. With continued exposure, this is going to induce fibrosis. And so again, the air spaces are taken over. You can kind of see here's a normal alveolar wall, and it's all of this inflammatory tissue is taking over. You're starting to see some collagen and fibrin being extracellular matrix particles being laid down. Over time, you'll get more and more fibrosis with this. You can tell this is an inflammation. Anybody know what kind of cell this might be? Giant cell, yeah. What forms giant cells? What's that? Macrophages, yes. So this is a multinucleated macrophage. And do you remember that giant cells tend to be formed, they can form in granulomas, but they can also form around foreign bodies. So sometimes hypersensitivity pneumonitis can be caused by silica, which is like glass workers will get exposed to that, or asbestos. So those asbestos are these little teeny tiny hair-like fibers that get inhaled, and they can wedge in the alveoli, and they can cause these giant cells. So they're little foreign bodies that cause a big inflammatory reaction. So that's hypersensitivity pneumonitis. Okay, we'll leave it there. Have a wonderful weekend, and I will see you guys next week.